Thank you for joining us for this episode of Exploring Gut Topics, Advances in Gastroparesis Research. My name is Cecile Rooker. I am the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. We started Exploring Gut Topics as a way to dig deeper into some of the questions that we hear from the patient community who contact our organization. We hope that you will join us each month and learn a little bit more about a new topic. Today, our topic is about gastroparesis. We're taking a deeper dive into the latest research on gastroparesis, and we'll be specifically looking at the research conducted by the Gastroparesis Clinical Consortium, which is sponsored by the National Institute of Health's center called the National Institute of Diabetes, Digestive, and Kidney Diseases, or NIDDK. Those of you who follow IFFGD program have probably heard us speak about NIDDK often. NIDDK is one of the many sections of the NIH that does research into gastrointestinal illness and probably has the largest portfolio of research in our disease community. Years ago, they started the Gastroparesis Clinical Research Consortium. This consortium focuses on the etiology, natural history, and therapy of gastroparesis. The goal of this consortium is to perform clinical, epidemiological, and therapeutic research in gastroparesis and provide an infrastructure that can rapidly and efficiently design and conduct clinical trials for effective medical, surgical, and other interventions to improve treatment of patients with gastroparesis. Additionally, the consortium conducts mechanistic studies to understand the pathophysiology of gastroparesis. In a nutshell, they study all aspects of gastroparesis. We are so lucky today to have two members of this research consortium with us today. Today we have Dr. J. Pasricha. Dr. Pasricha is a professor of medicine and the director of the Center of Neurogastroenterology at Johns Hopkins University. Thank you, Jay, for being with us today.
Thank you, Cecile. It's a pleasure to be here.
We also have with us Dr. Madhu Grover. Dr. Grover is an associate professor of medicine and physiology at the Mayo Clinic in Rochester. Good morning, Dr. Grover.
Thanks, Cecile, for having me.
And thank you both for taking time out of your really busy schedule, especially these days, to speak with us about some of the research being done at the Gastroparesis Consortium, and specifically about a paper that was recently published in the February 2021 issue of Gastroenterology, which is a prominent journal in the field of gastrointestinal disease. The article that I specifically want to look at today is entitled Functional Dyspepsia and Gastroparesis in a Tertiary Care are Interchangeable Syndromes with Common Clinical and Pathological Features. For those of you at home, Drs. Pasricha and Grover were the first and second authors on this research paper. This is actually a really groundbreaking paper. To me, I feel like it really answered a lot of questions that the research community has had. But before we start talking specifically about that research study, maybe we could back up a little bit and talk about this research consortium. Dr. Grover, can you give us just a little bit of history about why it was started and what its goals are?
Sure. So, the Gastroparesis Clinical Research Consortium, or the GPRC, as we call it, it was established by NIH and specifically NIDDK back in 2007. So we are in our 15th year of the consortium. And the idea behind, setting this up was to really transform our understanding of etiology, pathophysiology, natural history of gastroparesis, as well as to conduct, treatment trials. Furthermore, as you alluded in your introduction, we really set our goals high to take gastroparesis from a black box entity in those, years of early 2000s and really, transform what we know about this disease and really to understand mechanistically what's happening in the stomach, what's happening outside the stomach in these patients with gastroparesis. So those were the overarching goals of the consortium, and we have, proudly achieved many of those goals, as I'm sure you have seen from the work published over the years, through our registries, through the clinical trials we have conducted, through the mechanistic studies we have conducted. And more recently, we have expanded our consortium to include pediatric cohorts as well. So we are really proud of what the consortium has achieved, and all of that effort goes to the patients who have participated in our studies. Really a remarkable interest from the community to enroll in our mechanistic studies, in our treatment trials, as well as to the investigators across the consortium who have really spearheaded these efforts to conduct these large studies.
If I may add something to that, very nice description by Madhu. And this goes, I think, very close to the question that you started with. This consortium arose from significant engagement with the patient community. Prior to the NIH actually starting the funding, there were a series of meetings held between physicians who were taking care of these patients and patient support groups. We actually had a large meeting at one of the GI DDW, which is a big meeting, which we brought all of these stakeholders together, including the NIH. And we impressed the NIH with, what a large unmet need there was. And to their credit, they went through the series of steps that they had to take, eventually ended up funding this. But I will say, without the engagement and support of the patient community, this consortium would not have been started. And I'd like to say that the reason for this consortium to exist is because of the patient community. And we want to make sure that going forward, we remain responsive and true to our roots.
Absolutely. Thank you, Madhu and Jay. That's really true. I do remember all of the great advocacy effort that came from the patient community to help create this consortium, to bring about the Gastroparesis Awareness Month, to really sort of raise the bar of awareness about gastroparesis. And then you guys and all the rest of the wonderful research at the consortium really took that flag and ran with it and have published just a multitude of wonderful research about the disease. And we see a lot of great things coming from the consortium. Here in 2021, there have been quite a few papers that you have published here recently. And it really is fantastic to know that there's so much research going on for this community. Talking about this one specific paper, and it really was it was very large, and it was a really well done, large population-based study. I mean, it felt like you had a lot of patients in that study, and you did some really good groundbreaking work looking at functional dyspepsia and gastroparesis in the tertiary care centers in which you work, and how they are interchangeable syndromes, how they're similar, and in pathology and clinical symptomology. Jay, can you tell us a little bit more about sort of the outcomes of this paper? I realize it was a lot of data and there were a lot of things that came out of this research study, but sort of what's the bottom line? Without reading the 80 pages of this great paper, which I read myself. But what can we say? How can we boil this down for the patients to understand? What does this really mean to them?
Thank you. So I'll tell you about the major findings of the paper, and then I'll also spend a little bit of time trying to explain what the implications are for patients and for other stakeholders. Part of the consortium objectives, we had from the onset decided to include a group of patients. We didn't know what to call them. We used to call them gastroparesis-like syndrome, chronic unexplained nausea and vomiting. But these were patients who would come to us, and before we did any formal testing, we could swear almost that they had gastroparesis. But to our surprise, when we actually did the gastric emptying, it came back as normal. And these patients were just as sick as the ones with delayed gastric emptying. So we included them in our cohort of patients that we followed. And in this paper, basically is a culmination of, over 10 years of research studying these patients and comparing them to those with delayed gastric emptying. And what we found were several things. First, both groups are almost identical in terms of their clinical severity. So regardless of whether they had normal emptying or delayed emptying, they were just as sick. Their nausea was just as severe. They were still seeking the same kind of medical attention, and some of them were in fact on TPN or parenteral nutrition because they couldn't take anything by mouth. So that was the first thing. The second thing is when we followed their long-term outcomes after a year or more, they didn't get better. Just like most gastroparesis patients in our study don't get better after a year, these patients also had the same rate of improvement, which was very low, about 25 to 30% at best. The third thing that we found was when we actually examined the stomachs in the few patients that went to surgery, and we got an opportunity to obtain full thickness biopsies so we could look at the deeper layers where the nerves and the muscle are. We found the same pathology in both groups. Now, there may be some shades of difference in terms of severity, but essentially the pathological signature in patients with normal gastric emptying was the same as those with delayed gastric emptying, which was a aberrant response of a particular kind of immune cell called the macrophage, and the loss of a cell that's responsible for the rhythm and efficiency of contractions, which is the ICC, or the interstitial cell of Cahn. And then finally, and perhaps most surprisingly to us, because clearly the absence or presence of delayed emptying was not distinguishing these patients, we said, let's repeat gastric emptying in a year. And in a subset of patients who came back to us after a year and got the testing done, we found that about 40% or a little more than 40% of patients who had delayed gastric emptying at the onset after a year had normal emptying, and vice versa. Those who had normal emptying, about 40% or so, developed delayed emptying. Now, nothing had changed as far as their symptoms are concerned. Patients were just feeling the same. All that had changed was the gastric emptying. Now, so we've concluded that these patients are basically part of the same spectrum of disorders, pathologically and clinically, and that gastric emptying is not the best way to make a diagnosis of gastroparesis. So what are the implications? The implications is not that gastroparesis is more like functional dyspepsia. It's the opposite. Functional dyspepsia is actually part of the gastroparesis spectrum, and we should perhaps not call it functional dyspepsia anymore. We should just call it as part of the gastroparesis family. And we can come up with names, but that's not important. The important thing for patients is those who had normal emptying should be recognized as having a real organic disease, number one. Number two, it gives the advocates for gastroparesis now a lot more leverage, because if you think there are, one out of, for every one patient with delayed gastric emptying, there are probably 10 with normal emptying, and they have been incorrectly assumed to be a separate problem. And so the gastroparesis community has always struggled with, well, we're small number of patients and, nobody's paying attention. Well, it's no longer that. There is a large group of patients. And if you look at the prevalence of so-called functional dyspepsia, it's up to 10%. 10% of the US population. That's a huge number. And I think this should be really cause for encouragement that gastroparesis is not an isolated small disorder. You are not alone.
How wonderful for patients to hear that, because sometimes they feel like they are struggling all by themselves. And then they're able to find these support groups, and there's some fantastic ones out there where there's several of them and they band together. But, really and truly, those people who feel that their doctors have told them no delayed gastric emptying, you don't have gastroparesis, they feel so isolated, right? Because they don't feel like they belong. But really and truly, what you're saying is that they do. that they are part of the gastroparesis cohort and the community, and that they are really part of that gastroparesis
spectrum of disorders.
the spectrum, right?
And
Absolutely.
they should be treated as seriously as the ones with delayed emptying. And by the way, the ones with delayed emptying may have normal emptying a year later and may be dismissed by the doctors that your gastroparesis has resolved. It hasn't.
Right.
The emptying has changed, but the disease hasn't resolved. And you can't be dismissed for that reason alone. The other thing that's really important is the implications for drug development. There is no approved drug for functional dyspepsia in this country because nobody really has been able to say what the disorder really is. Is it in the head? Is it, gut-brain axis? Whatever. We're saying this is a real stomach problem with real pathology. And now pharma can start taking it seriously as well and perhaps develop drugs. And obviously pharma is a for-profit industry. With those large numbers, 10% of the population, now perhaps we're going to attract a lot more. And this will benefit everybody who's traditionally been called gastroparesis, as well as those who've been traditionally called functional dyspepsia, this huge, large spectrum of patients.
Also allows for easier enrollment, right, in clinical trials. When you have a larger number to ask to participate, that ups this just statistically. Then if you can only ask 1,000 patients, you might get a certain percentage that say yes to a clinical trial and actually meet criteria. If you have 10,000 patients who meet criteria, right, then to be in the trial, then you're able to complete these research studies so much faster and get drugs to the market faster, and patients get treatment and relief from their symptoms, which really is ultimately the bottom line, what we are looking for.
Yeah, in fact, this is very relevant because there are several trials right now by drug companies on gastroparesis because the FDA still defines gastroparesis by delay in emptying. So they have to meet that criteria to be able to enroll. In the meantime, for every one patient that they're able to enroll, there are 9 patients out there who are just as sick, have the same problems, just as nauseous, but they can't get into the trials. I think so. This is the beginning of a process by which we are going to reset the framework by which these patients are viewed, and it has implications for all of these things that we've talked about.
Yeah, I mean, as an extension of it, the way I see it, we would like to impact as many lives as we can and, transform our treatments as well as our understanding of sort of the spectrum of conditions. And I think I would like to pick up on the point that Jay alluded to is I see this clinically all the time. Hey, my gastroparesis is resolved, but I'm still suffering. I still have the exactly same symptoms and nobody wants to take me seriously anymore. So I think this is a call for those patients and an understanding that once you have that disorder, you have that disorder. And ultimately, your symptoms need to be managed. And yes,
Right.
Your gastric emptying can fluctuate over time, but it doesn't take that disorder away from you. So I think that's an important thing for clinicians as well as for industry to remember is that sort of labile nature of gastric emptying. And just as an extension of that point, the work that we envision in gastroparesis in the upcoming cycles, hopefully, and I know you have a question about that later, but we would like to, this is a starting point, as Jay has mentioned. I think we are just at the beginning of our understanding of, if you can call it dyspepsia or CUNV or spectrum of gastroparesis. I think much more needs to be done in that disorder. And I think much more also needs to be done in how we understand gastric emptying. And we have some really interesting efforts ongoing to try to get more out of gastric emptying assessments and how the stomach really accommodates, really performs the motor function, and what's the role of pylorus and emptying out of the stomach. So I think we are really at a point where we have learned a ton, and there are some really fancy technologies and techniques that are available to us to use, which will transform how we think about gastroparesis and dyspepsia over the upcoming years.
That is so fantastic. So let me ask you a question. So, with this research in mind and all the other great research that you guys have done at the consortium, is there any reason that we should think to categorize a patient as either gastroparesis versus unexplained chronic nausea and vomiting versus functional dyspepsia? Are we talking a full spectrum of disorders, or is there any reason that we might want to categorize them as one or the other?
Right.
Sure.
I think, my opinion is that the burden of proof now is on the splitters to show that there is a reason to do it. We are saying they are part of the same spectrum. Now, there are some patients who have very severely delayed gastric emptying. They may never revert back. And that's fine. That's why we call it a spectrum. We rather call these as gastric neuromuscular disorders. We want to do two things, right? One is obviously find the truth, wherever that leads us. But we also want to dispel the stigma that comes when you label something as organic versus non-organic, right? So functional dyspepsia has been called non-organic, and there's nothing wrong with the organ. And it's not true. And it's not just that it's not true, but the baggage that it sort of generates for patients is enormous because nobody really takes them that seriously anymore. And we want to dispel that. So nomenclature is important, right? It has consequences. So we have to think this very carefully about how we're going to actually rethink what we call these disorders. Last thing I want to do is replace the term functional dyspepsia by another functional term. No, that's not where we want to go. But, it's a start. We have to convince the community of physicians and investigators. And hopefully others will actually reproduce our studies. And there is actually a lot of literature now that's coming up that is showing that gastric emptying may not be that useful anymore in distinguishing these disorders.
Very good. I agree. I think that a lot of patients are very confused. If you go to one doctor and you get one diagnosis, you go to another doctor, you get a different diagnosis. And your study, especially with showing the pathology of those full thickness biopsies, is showing that the actual stomach itself is damaged in some way in both of them. So it is definitely the patients that feel that they're being dismissed should definitely be looking for a doctor who's really willing to treat them for what they do have, which
you have to remember, Cecile, this is a almost a century-old paradigm that we are trying to disrupt, and changing the narrative will take time, but studies like this are needed. I mean, without these kinds of studies, we could be shouting from the rooftops, something which I always believed in, that these diseases are similar, but I can't convince my peers and other stakeholders unless we do the studies like this. This is why the consortium work is so important, and this is why patient engagement with the consortium is so important. Together, we can change the narrative, and we're doing this for the right reasons. It's not about establishing nomenclature.
Absolutely. The goal in the end is to help as many patients as possible, and by widening that, our understanding and this research, which I am so grateful at the NIH for investing in this types of research, which I know is long term. It has high cost to the NIDDK, but I feel like it's such a great investment for us to be able to really begin to lay the groundwork for all the future research studies. And talking about future research studies, Dr. Grover, you hinted a little bit about what the consortium is looking at doing in the future, but can you give us a little bit better idea of what can we look for? What can we get excited about that's coming next?
So multiple things. I mean, there are, it could be a sort of a whole conversation of itself, but we are really excited with the findings we got from the dyspepsia cohort. And one of the efforts is to have that cohort also represented in a much higher proportion in the upcoming studies, not to cut out the gastroparesis cohort, but to understand both of them. We are also thinking and looking into ways, and these are ongoing studies, as to how we can do gastric emptying in a much better way. Whether, dynamic assessments of gastric emptying taken at different time points rather than a static image would be more informative. We are thinking about ways how to assess pylorus in these patients. As you know, there's a lot of interest in doing pyloroplasty or pyloromyotomy or GPOM procedures, but the mechanistic understanding is still lacking quite a bit. So we have new studies and ongoing efforts on a new grant that Jay has to do a randomized trial to really understand who are the patients who get better with GPOM, what are the characteristics of those patients, so that we can identify rather than just doing it on everybody or anybody. From a mechanistic standpoint, we have a whole set of studies, and one of the interesting one I would highlight is a GWAS study that we are engaged in, where we have done exactly what Cecile you were alluding to, is to take a lot of patients without really a priori having a name for them, and then to study or understand would they separate out in different categories, better than what dyspepsia and gastroparesis and these terms do. So we have DNA collected thanks to the consortium's efforts over the last 15 years. We have DNA collected on close to 1,000 patients. Most of them are gastroparetic, but some are dyspepsia and some are chronic unexplained nausea, vomiting. So we're trying to understand genetic associations with these disorders. So that would be one of the largest studies of its nature for the field. We have another exciting study where we are doing multi-omics in the stomach wall. So the tissue we get from the stomach wall. We have done things like transcriptomics and proteomics in smaller cohorts of patients, but with the upcoming study, we are hoping to do a number of assessments in the same tissue to allow us to do systems biology type approaches to identify, okay, what are the targets that show up at RNA level, at protein level, and what are the signaling pathways that can be targeted. So we are seeking out partnerships, even with industry, to do some of that work. So we are really, and then the clinical trials, they go without saying. I mean, they have been one of the most impactful work of the consortium. The aprepitant clinical trial that Jay led, and he can perhaps expand on that, that will hopefully really transform and bring to the table an FDA-approved drug for gastroparesis, hopefully not too long from now. We have also done trials that have shown us the drugs that do not work very well. Nortriptyline is an example. So I think a well-conducted study helps with both understanding what works and what doesn't. We have done studies looking at insulin administration and how that can be effective in diabetic gastroparetics. And we will continue to expand on the clinical trials as well. Again, as I said, I can go on and on, but I'll stop at that.
I may just add a couple of things to that very long list of focusing on future studies. One is, my passion and our passion in the consortium is to cure gastroparesis, not just to treat the symptoms. And as we gain deeper insight into what's causing it at the level of pathology or at the level of genetics, we are coming closer to actually doing what's called disease-modifying therapy and not just focusing on symptoms. This is like, for instance, if you had rheumatoid arthritis, right now we're giving ibuprofen to relieve the pain or Tylenol to relieve the pain. What we want to do is do what people in rheumatoid arthritis have done, give them biologics or methotrexate or something else that actually cuts down on inflammation. So that is the most exciting, I think, future direction for us to take. Secondly, we are looking for biomarkers, easy biomarkers that tell us whether this patient, in fact, has that signature that Madhu and his team found in the stomach of these patients, and whether that means going to new techniques where we can do full thickness biopsies by a simple endoscopic procedure, or actually looking for biomarkers in biopsies or in the serum. That's also going to be a very important advance for us, and it's going to really, really make it a lot easier for patients to be diagnosed as well as conduct clinical trials. And finally, I'd like to say, outside of the gastroparesis community, what the consortium has done is poster child for what can be done with consortia like this for motility disorders other than gastroparesis. I mean, talking about constipation, talking about irritable bowel syndrome. Similar efforts like this would have similar transformative effects. So hang in there. We'll get there.
Yes, I have to tell you, I can just picture in my mind several patients that were probably doing the happy dance during that really great summary of points for the future. One, that the consortium is still looking for the cure, that isn't something that is sort of on the back shelf, but that is forefront of what you're doing, and knowing that hopefully one day our research is going to get there. And I know that that's something that's really near and dear to so many people's hearts. Also, just knowing that you're not alone, that this research has shown us the breadth of patients that are suffering with these symptoms, that are gastroparesis spectrum, gastroparesis-like, whatever you want to call it, they are one. And they can find each other, they can network with one another, and they can help each other, and that they can join together with the research consortium, and patients and researchers can come together to really do some great things for the future. And I, for one, am extremely excited about the possibilities. This consortium has done so much in the last 15 years. The understanding is just jumping by leaps and bounds. I feel that we are just gaining so much understanding of what this real spectrum of disorders is really about, and how patients who are suffering with this chronic nausea and vomiting and pain really and truly can begin to get a true diagnosis. The fact that you're looking for the biomarkers to make it faster is so, I know, probably more happy dances from the patient population, because I've talked to patients at 6 to 8 years to get a diagnosis. And then, so then that is just so much wasted time within their lives, suffering. And knowing that these are some of the top things on both of your minds as top researchers in the field, but also the consortium itself, is really, really, really just a heartwarming thing for me. And on behalf of all the gastroparesis community and the GI community as a whole, all of this sort of makes a ripple down effect of implications of what can happen in other disease states as well, as you mentioned, Jay. And honestly, I have to tell you again, thank you for your research. Thank you for your patient care, and for the impact and the lives that you touch in your clinical practice, in your labs with your colleagues at Mayo and at Johns Hopkins. Thank you for caring about us patients and for doing this research. But mostly, thank you for taking time out this morning to talk with me about it so that I can share this information.
I want to add a note of thanks. I want to thank the patients. Patients are the ones who inspired us. This consortium would not have started without the patients. This consortium is about the patients. And we want to thank the patients for hanging in there. They have suffered terribly. We see them in the clinics, and we know what the suffering is. You're not alone. We're here, and we're going to try our best to get you better. Thank you.
Thanks, Cecile. I completely echo Jay. That's the driving force to improve the quality of life, to really cure and change the course of these patients, to hopefully get to a stage where we are no more just giving some symptomatic treatment, and hopefully reverse and cure the.
This is not an academic exercise for us.
Yeah. And I would like to thank you, Cecile, for being a voice for the patients and bringing that voice to us, and then taking our voice back to them. And it's really critical, the mission of IFFGD and the work you do, because I think there is, the more interface we can have, the better it can guide our thinking, and the better it can guide our research. And it will allow patients to really know and understand what we are finding, what we are hoping to find, and what we are thinking. So I really thank you for your efforts as well.
Thank you so much. It is such a pleasure to have this role as a patient myself, and I have 3 daughters, 2 of which are GI patients. I definitely have a very vested interest in the research and in informing of the patient community. And it's an honor to have this position at IFFGD and to be able to work with great researchers like yourself and the wonderful patients that I speak to every week here at IFFGD. And so I look forward to bringing all of us together more and more often and bridging that gap as often as IFFGD can to ensure that we are on the same page, that we are moving forward, not backwards, not standing still, but really sailing the ship forward and making a difference. And I appreciate everyone that has contributed to this. This has been a fantastic, informative session of exploring gut topics. And for those of you at home, thank you for joining us today and learning more about the advances in gastroparesis research that are being done by the Gastroparesis Research Consortium. We hope that you've learned a lot. And if you have any questions about today's program or any questions that you just feel like that you would like to ask, feel free to always reach out to IFFGD@iffgd.org and ask us your questions and talk to us. Let's continue the conversation and let's work together with these researchers to make an impact on tomorrow and bring those cures that we so desperately need here in the gastrointestinal illness community. Thank you so much for watching, and I hope that you'll join us next time on Exploring Gut Topics.